Okay, let's dive right into this. Welcome to the explainer. Right now, as we're speaking, there's a good chance one of the most high stakes, microscopic action stories is happening somewhere inside your body. Today, we're unpacking acute inflammation. And we're not just talking about the swelling you ice after a tough workout, right? We're looking at the incredible, highly coordinated cellular emergency response that is strictly designed to keep you alive.
So let's ground this in something we've all felt. You grab a piece of rough firewood and bam, splinter. It hurts, it turns red, it swells up. But what's actually happening under there? How does your tissue instantly know it's been invaded, and how on earth does it mobilize a counterattack in those first crucial hours?
Which brings us to Section 1, the body's emergency response.
You see, inflammation is a stereotyped response. Basically, living vascularized tissue reacts in a highly predictable way to sound the alarm. Think about physical agents, like mechanical trauma, or that splinter, or even severe heat, versus biological infections, like bacteria, viruses, or fungi. Your body actually responds identically to both. It really doesn't matter who the enemy is. Your tissue mounts the exact same initial counterattack.
And when that biological alarm goes off, we get the famous 5 cardinal signs of localized inflammation. These are the physical things we actually see and feel, straight from the Latin. We've got rubor, that's the redness; calor, the heat, making the spot noticeably warmer; tumor, the swelling; dolor, the pain and tenderness; and finally, functia lessia, which is the temporary loss of function in that specific area. Every single one of these physical signs, they're the direct result of a microscopic battle raging right below the surface. Moving on to Section 2, Phase 1, Vascular Events. Now, to fight off an invader, the body has to rush its white blood cells to the battlefield. It's kind of like widening the highways for emergency vehicles. There's a clear 3-step roadmap here. Step 1, vasodilatation to boost blood flow. Step 2, increased vascular permeability, allowing things to leak out. And Step 3, leukocyte emigration, which is simply getting those defense cells out of the blood and into the tissue. Take a close look at how Step 2 actually works here. Local cells release chemical mediators, most notably histamine. This histamine hits the vascular smooth muscle and causes those endothelial cells lining the vessel to literally contract and pull apart from each other. It happens incredibly fast, popping open these microscopic gaps right in the vessel walls. So the highway hasn't just been widened, the barricades have completely opened up. And because those gaps are now wide open, fluid just comes rushing out of the bloodstream and floods the surrounding tissue. This brings us to a super important piece of jargon: exudate. Exudate is this escaping protein-rich extracellular fluid. Remember those 5 cardinal signs we just went over? Well, this escaping exudate is exactly what causes the tumor, that physical swelling and tension you feel around your splinter. The heat and redness, that's just from the increased blood flow of the vasodilation. See, the microscopic mechanics perfectly explain the macroscopic symptoms. All right, Section 3, Phase 2, Cellular Events. Now, what's really interesting about this next phase is how we actually maneuver the troops. So, the highway's widened, the exits are open. As that protein-rich exudate leaks out, the blood left behind naturally thickens up. This increased viscosity leads to blood stasis. White blood cells, which normally love to cruise in the fast lane right down the center of the vessel, get physically shoved to the peripheral edges in a process known as margination. Once they're pushed to the edges, this genuinely fascinating mechanical interaction kicks off. In Step 1, the leukocyte doesn't just slam on the brakes, it starts this process called rolling. Both the endothelial cells on the wall and the white blood cells themselves express these receptors called selectins, specifically L, E, and P selectins. Think of them like temporary cellular Velcro. They grab the cell, slow it down, let go, and grab again. It makes the white blood cell literally tumble and roll right along the inner wall of the blood vessel. As it's tumbling along, the cell gets activated by chemical signals called chemokines, which triggers stable adhesion. The white blood cell deploys these heavy-duty surface proteins called integrins. So if selectins were the weak Velcro, integrins are like a heavy-duty deadlock. They bind incredibly tightly to ligands on the endothelial surface, bringing the rolling cell to a firm, complete stop right next to the exit gap. Which brings us to the grand finale of the escape. Steps 3 and 4 show a process called transmigration or diapedesis. The firmly adhered leukocyte actually changes its physical shape and squeezes itself through those interendothelial spaces, those little gaps we mentioned earlier. It forces its way through the vessel wall, leaves the bloodstream entirely, and drops right into the surrounding tissue where that splinter or bacteria is waiting. Section 4. Target, engage, and destroy. Okay, so the troops have landed in the dense, dark tissue. But how do they actually find the splinter? They use chemotaxis. This is locomotion along a chemical gradient. It is exactly like trained search dogs tracking a scent. The damaged host tissue and the bacteria themselves are throwing out chemical distress signals, things like bacterial peptides. Check out the graded color bar here, representing the concentration of those chemotractants. With its senses totally locked onto this chemical trail, the white blood cell migrates directly toward the highest concentration. It blindly but purposefully navigates through the tissue spaces until, boom, it bumps right into the invading bacteria.
And once it finds the enemy, it executes a highly coordinated three-step kill sequence known as phagocytosis. Step 1 is recognition and attachment. The leukocyte uses specific receptors, like mannose or scavenger receptors, to lock onto the microbe. Step 2 is engulfment. The cell literally extends its membrane, wraps it around the particle, and swallows it whole into a temporary pouch called a phagosome. Finally, in step 3, that pouch fuses with a lysosome, forming a phagolysosome. This basically drops the enemy right into the cell's internal digestive chamber. No way out. Inside that sealed chamber, the final destruction happens. The leukocyte unleashes an absolute barrage of toxic oxygen radicals and destructive proteolytic enzymes. Using both oxygen-dependent and oxygen-independent mechanisms, the phagocyte completely melts down and destroys the invading microbe. The threat is neutralized, the necrotic tissue is cleared out, and the body's emergency response has done its job perfectly. So as we've seen today, acute inflammation is this magnificent, rapid onset process. It's a highly orchestrated emergency response full of widening blood vessels, rolling cells, chemical tracking, and intense microscopic destruction. It's absolutely crucial for our survival. But here is the big question I want you to take away from this explainer. This whole system is designed to be a fast, intense fire that puts itself out the second the threat is gone. What happens when that fire gets confused? What happens when it fails to clear the threat, or it just stubbornly refuses to burn out? Well, that crosses the line from a life-saving acute response into the incredibly dangerous territory of chronic inflammation. And honestly, that is a fascinating topic we'll have to tackle another day.